So drugs used in congestive heart failure. Okay, so before that really we go to the treatment portion, let me build up some concept regarding the failing heart. You know, there is one term that is known as cardiac output. Cardiac output, the relationship with cardiac output with the heart rate and stroke volume is directly proportional. That means you increase the heart rate, you increase the cardiac output. You increase the stroke volume, you increase the cardiac output. Now what is the cardiac output? To understand the cardiac output, you need to understand the heart rate. You already know that heart rate, it is the beating of your heart, beating of the ventricles, beating of your heart per minute. That means you already, and you know who set this beat. It is your SA node. That means per minute your SA node generates 60 to 80 beats per minute. So your heart rate means it is beating of your heart per minute. Now coming to the stroke volume. What is the stroke volume? You know the stroke volume. To understand the stroke volume, you need to understand the two definitions rather. One is EGV, another is ESV. You know what is EGV? EGV means it is end diastolic volume. End diastolic volume. Whereas ESV is end systolic volume. End systolic volume. You know what is end diastolic volume? It is the end diastolic volume means the blood present in your ventricles before ventricle contracts. That is amount of the blood present in your ventricle, both the ventricle, before it contracts. That means amount of blood present in your ventricles before contraction. Before contraction. And the remaining part of the blood after contraction in your ventricles is your end systolic volume. That is remaining part after your ventricle contracts, after contraction. Okay? And the diastolic volume per beat, your ventricle receives around 120 to 140 ml of blood. Okay? And your end systolic volume, the remaining portion, when it ejects the blood into the circulation, the remaining part, that is your end systolic volume, is around 50 to 70 ml. So stroke volume is equals to end diastolic volume minus end systolic volume. So it is around, say for example, 140 minus 70, it is 70 ml per beat. That means it is the total volume of the blood that is ejected by your ventricles per beat. So what is the unit here then? It is ml per beat. So beat and beat cancel each other though. Then what is the unit of cardiac output? It is ml per minute. That is the total volume of the blood that ejects from the ventricles when ventricle contracts into the circulation per minute. That means how much your volume of the blood ejected by the ventricles per minute. You calculate it. Say for example your heart rate is around 60 to 80. So we will take the average. Let it be 70. Then stroke volume 70. So it is around 4900 ml of blood that is ejected per minute by your ventricles. That is approximately 5 liter per minute. So this is your cardiac output. That means this is your cardiac output. Okay. Moving further, To analyze this, we are going to dig this stroke volume little bit more. You know, stroke volume depends on preload, contractility, and your afterload. Let me tell you here these three things. You know what is the preload? First, whenever, that means whenever your ventricles fill with the blood, it creates a tension in the myocardial wall. That means, say for example, this is your myocardial wall, and this is your end diastolic volume. This end diastolic volume creates a stretch on the myocardium. When it creates a stretch on the myocardium, this stretch develops tension. This stretch develops tension. And this tension is responsible for development of pressure. You know, this stretch on the myocardium is your preload. This is actually stretch on the myocardium. Stretch on myocardium is your preload. That means more the stretch, more is your preload. That is your one law. Let me tell you that law. Keep it here. That means there is one law known as Starling Law. Starling Law states that the more you stretch your ventricles, the more is your cardiac output. The more is your contraction. The contraction is directly proportional to the preload. That means, say for example, I'll make you understand very simply. It's a Starling Law. Say for example, how much volume normally your heart receives per beat. That is end diastolic volume versus stroke volume. Okay, we can say versus cardiac output. End diastolic volume per beat received by your ventricle is around 140 ml. Okay, and you know, it ejects when it beats, it ejects 50% of this volume, 50% of the end diastolic volume. That means normally it ejects around 70 ml of blood per beat into the circulation. Okay, that means your normal heart curve is like this. That means at given stretch, at given end diastolic volume, it produces contraction that led to the ejection of 70 ml of the blood, 50% of the blood into your circulation. That means your normal heart works at this position. Okay. Now, whenever there is increase in the stretch, as per the Starling Law, there is increase in the cardiac output or stroke volume. That means if you increase the volume, say for example from 140, you are increasing to 200 ml. So then your expected outcome is around 100 ml. It's okay, expected is 100 ml. How this end diastolic volume increases? You know, there are so many things which increases the end diastolic volume. Let me tell you few here. There is one concept to increase the end diastolic volume. You know, the lower portion of the body, they send the blood towards your right ventricle through inferior vena cava. Whenever you do massaging of your legs, you know, this is massaging, this is called milking process. When you do the milking process, it causes, actually your vein is circulated. This is your vein, and your vein, outside the vein there are muscles, And when you do any kind of massaging to these muscles, it pushes the blood from the lower portion towards the heart more. That means it increases the preload. Whenever you increases the preload, that means you are increasing the end diastolic volume. This is increase in the end diastolic volume leads to increase in the cardiac output. There is one thing, that is milking process. Milking. Number second is normal physiologically. Number second is breathing up. That is known as respiratory pump. Respiratory pump. You know what is respiratory pump? Respiratory pump, whenever you do deep breathing, you are inhaling deep breaths. When you are inhaling the deep breaths, that means you are creating a pressure difference between the abdomen and the thoracic cavity. And that means when you take deep breath, you are creating more abdominal pressure and less thoracic pressure, and that led to the suction of the blood from the abdominal portion towards the heart, that is towards the thoracic cavity. That also increases your EDV. There are drugs, vasoconstrictor drugs. This also increase the end diastolic volume. There is we can say increase in the calcium. This also increases the end diastolic volume. There is hormones like T3, T4 hormones. These hormones also increases the end diastolic volume. Okay, now your end diastolic volume increases is by these activities. Okay, now what happened to the failing heart? Say for example, my heart develops an ischemia. My myocardial wall become weak. When my myocardial wall become weak, how it become weak? Because of low supply of oxygen. They are utilizing low oxygen. So say for example, my heart develop ischemia and my myocardial wall become weak. And when my myocardial wall become weak, it is not going to produce full contraction. When it is not going to produce full contraction, that means it is not going to eject the stroke volume against the given amount of end diastolic volume. Then let me tell you here one thing that is known as Laplace law. That means pressure is directly proportional to the tension created here in the myocardial wall, inversely proportional to the radius. That means whenever you are what is the primary pathology in the failing heart? There is decreased tension. When there is decreased in the tension, that means they are decreasing the pressure. Okay, come here. That means the same amount of at 140 ml of the blood received per beat by your ventricle in the failing heart, he is not able to contract 70 ml, but say for example it contracts around 50 ml of blood into the circulation. 50 ml of blood into the circulation. What does that mean? What happened to the curve? This curve drop downs like this. This is the curve of a failing heart. That means at given volume of end diastolic volume, they eject only 50 ml. That means your heart will drop from position number 1 to the position number 2. It's a failing heart. Now, whenever such conditions occur, if your heart failure is of short duration, that is of say for example 5 to 10 hour heart failure, then if you increase the end diastolic volume as I told you by milking process or by breathing or by giving the drugs, that means you are trying to help your heart by increasing the end diastolic volume so that it produces the tension. Okay, it produces the tension. That means that is here at point number 2, compensatory mechanism come into play. That compensatory mechanism is sympathetic nervous system. Let me tell you, when your heart failure is of shorter duration, this sympathetic nervous system is very helpful for heart. How? You know, let me tell you, let me make you understand what will happen. You know, say for example, in a failing heart, how much volume is here? 140 ml and diastolic volume. And when it's a failing heart, it is not producing so much tension, it is not producing stretch so much, so that when it contracts with low pressure, and low pressure, low stroke volume is there. That means only 50 ml is in the circulation. That means it is having low pressure in the circulation. When there is low pressure in the circulation, there are few important receptors which are present at the walls of the aorta and here at the carotid sinus. When the low pressure blood hits these receptors are known as baroreceptors, stretch receptors, or we can say pressure receptors. They sense the pressure, whether your pressure is low or increased. They sense that pressure is low. What they will do? They inform your medulla oblongata structure solitarius nucleus that your pressure is low. That pressure is low inside the body. So do one thing: initiate the firing from sympathetic nervous system. What the sympathetic nervous system will do? Then you know there is sympathetic outflow of epinephrine or epinephrine sympathetic branches. One of the branch goes to your right atrium. Here, right atrium at the SA node where beta 1 receptor is present. It tells the heart, increase the heart rate, increase the beating. When you increase the beating, that means when you are increasing the beating, you are increasing the heart rate. When you are increasing the heart rate, that means you are increasing the cardiac output. Good thing. Second thing, one of the branch is also going to the myocardial cells. It tells there is also beta 1 receptor. It tells the heart that increase the force of contraction. Increase the force of contraction. The increase in the force of contraction is known as inotropy. Inotropy. And increase in the rate of contraction, heart rate, it is known as positive chronotropy. That means initially it is doing good thing. Increase the heart rate, increase the contraction. But this is good only when there is the failure for, say for example, 5 to 10 hours for this much period of time. So what they are doing, this increases the heart rate, this is increased contraction. Now where the problem lies. If your heart is chronic, it is having chronic failure, that means it persists for very long, then that sympathetic nervous system is deteriorating, or it is very bad for your heart. How? I will tell you. You know, there are some branches of the sympathetic nervous system which goes to your arterial side. There, your receptors are waiting for this to. That means it causes arterial constriction. You know what does arterial constriction do? It increases the resistance. If it increases the resistance, your heart has to work, because your heart is producing low tension, low pressure. That means if you increase the resistance, you are increasing the efforts of your heart to act against more peripheral resistance. This is known as, that means the increase in the total peripheral resistance increase the load on the heart. What, in other words, this is your afterload. This is total peripheral resistance. Whenever you increase your total peripheral resistance, you are decreasing your cardiac output. It's having relation with the cardiac output. You are decreasing your cardiac output. Now, let me tell you more thing. Not only that, whenever your heart, one of the branch of the sympathetic nervous system, goes here at the venous side, and when it causes the venoconstriction. What venoconstriction do? It increases the return towards the heart. through inferior vena cava, or it increases more blood. That means it increases the filling of end diastolic volume. When it increases the end diastolic volume, that means it increases the preload, it increases the stretch. But remember, this heart is having myocardial, this is having weak tension. That means it is having weak tension. If it is having weak tension, it is not able to generate the contraction fully. At the same time, when you fill the ventricle with the blood, what you are increasing? The diameter of the blood. What you are increasing? The radius of the blood. That means you are increasing the radius of the blood. Whenever you are increasing the radius of the blood, that means you are decreasing further the pressure. Again, problem for the heart. Now, you know, not only this. See, there is one organ, important organ. Say, for example, I made here. This is your kidney. Okay. When there is arterial constriction, there is less perfusion towards kidney. When there is less perfusion towards kidney, you know what the JG cell going to secrete? The JG cell secretes more and more renin. What will renin do? JG cells produces more and more renin. You know what renin will do? Renin converts angiotensinogen from the liver into angiotensin 1, and this angiotensin 1 gets converted with the help of enzyme from the lungs that is known as ACE, angiotensin converting enzyme, into AT2. You know what is AT2? This is having intense vasoconstriction activity. It is having sympathetic stimulatory activity. That means this AT2 further constrict your arteries. This AT2 further constrict your vein. That is further increasing the afterload, further increasing your preload. That means this thing, and it is going to stimulate your brain. It is medulla oblongata. That means it stimulates here. If it stimulates the sympathetic stimulus, that means again deteriorating, again bad for heart. Not only this, your aldosterone. There is increase in the aldosterone from the adrenal medulla. Aldosterone. You know what happens when aldosterone increases? There is retention of sodium. When there is retention of sodium, there is always the retention of water. And when you are increasing the water, you are actually increasing the total blood volume. When there is increase in the total blood volume, you are increasing the preload. And when you are increasing the preload, you are increasing the end diastolic volume, you are increasing the radius, you are increasing more and more radius. That means you are decreasing the cardiac output, you are decreasing the pressure. Now, let me tell you again the same thing with different analogy.